Hello, everybody, and welcome to this symposium session. Really pleased to be with you. I'm going to share my screen and then we'll get going. Can I just check if the screen, can one of my colleagues tell me if the screen is being shown?
Yeah, if you could make it to that show mode.
Yes, coming now. Here we go. Excellent. So welcome to the session. As you can see from this slide, it's system stewardship and health system software. What's the research agenda? Can I ask at the beginning that you respond to the first poll, which is live? And can you, each of you, say hello to everybody else via the discussion forum, just saying who you are and where you're from, and then we'll be able to see who's here at the moment. So welcome. Just also a few of the usual housekeeping tips to remind you the various bells and whistles of this platform, where you can get live support, how to manage the screen function, and perhaps most importantly, where the Q&A function is. And please do use the Q&A function as we go through the session so that we can gather your questions as we move along. As you'll be hearing, we'll address them all at the end. So my name is Lucy Gilson. I'm the moderator for the session and really pleased to be here. Again, an encouragement to say who you are and to do the poll. Thank you. In this session, we're going to structure it as follows. There's going to be a brief introduction, which I'll give. Then there are 3 fascinating presentations about research relevant to stewardship and health system software. And we're going to take each of those presentations in turn. And then at the end of the session, we'll have time for an open discussion with the panel of presenters, considering your questions. But we also want to pose these 2 questions to all of us. What is system software? How is it relevant to stewardship? And what issues about stewardship and software need to be considered in future research? So we'll take time for your questions, but we'll also seek to have a discussion around those 2 particular questions. So the panel, and I'm just going to introduce them first. We're not beginning the presentations just yet. We're going to have an input that thinks about experience in India and England around stewardship of the medical profession. And I'm really pleased to be joined by Sumit Kane from the Gokhale Institute of Politics and Economics in Pune, and also the Nossal Institute in Melbourne, and Michael Calnan from the University of Kent in the UK. The second panelist is Steph Top from James Cook University, who's going to be talking about some Australian experience of relevance to our topic. And then thirdly, experience from Kenya and the UK thinking about patient experience. And I'm really pleased that we're with Dorothy O'Lough and Lisa Hinton, Dorothy from Kemri Wellcome Trust Programme, and Lisa from the University of Cambridge. So thank you to you all for joining in this session, and looking forward to engaging further with you. So just a reminder about the poll. I can say that we have 3 votes, so there are at least 3 people in the room, which is great, and hopefully we'll be joined by more. And I won't close the poll for a little bit yet. I'll keep it open, and then I'll share it a little bit later. Before I turn to the 3 inputs, I want to start by just presenting a few of the starting points for the session, a few of the concepts that the session is addressing. When I Googled stewardship just the other day, I found a wide range of terms linked to stewardship as reflected on this slide. A whole different set of dimensions in which stewardship is being used in relation to health, healthcare, and health systems. But what is stewardship? So the WHO report of 2007, the Everybody's Business report about health systems that provides a summary of the building blocks framework, specifically defines health system stewardship as about leadership and governance, and says it's about overseeing the whole health system, but importantly, in order to promote the public interest. Now that representation of the health system building blocks and the definition of stewardship was preceded in 2000 by the WHO annual health report, which presented the initial building blocks framework. And the phrase stewardship was used then. And this paper by Saltman and Ferrousier-Davis unpacks the origins of the term as it was used by WHO and the definition and meaning that they were giving to the term. I think it's important to remember and note that, as they say, bringing in the idea of stewardship was at that time a response to the influence of neoliberal economic thinking over social policy more generally. And that the idea was, in bringing the term in, was to really emphasize the idea that policymaking has both an ethical as well as an efficiency goal. And in their paper, they talk about the importance of infusing values into our understanding of what are otherwise quite technical perspectives on health systems. And they identify a set of concepts linked to stewardship that very much reflect on the notion of software: power, social purpose, trust, legitimacy, a sense of mission. Now, at the same time that WHO was producing its report, Saltman and Ferrousier-Davis were writing, the idea of health system software was also beginning to emerge and be discussed. And it was itself a reaction to the types of quite thin and technicist understandings of health systems that were then, and many would argue still are, dominant in the debates. This is a quote from Maureen McIntosh, a development economist, coming from outside the health sector, looking at the way we were talking about health reforms and saying how thin our understanding of health systems were, as if they were a set of rules that can just be rewritten. So in reaction to and in recognition of that concern, there was a growth of thinking about what health systems are and an emphasis on software issues. I wrote a paper in 2003 now that particularly spoke about the importance of trust and trust relationships as critical to our understanding of health systems. With other colleagues in South Africa, we also produced a monograph that spoke about health systems having human and social dimensions, and those being important, and the need to understand their everyday organizational realities. And then in 2011, just after the first Health Systems Research Symposium, Kabir Sheikh led a paper where it bringing in the recognition that all health systems are nested in wider political and social realities, power structures, interests, and that that's an important part of software. In Kabir's paper, there is this diagram that shows the evolution of understandings of health systems from, on the left-hand side, that quite technicist understanding about a focus on hardware, to the recognition of the combination of hardware and software, and then to the recognition of the broader socio-political context and its influence over systems. Blau et al. Talk about this idea of the software of systems and being important then in thinking about health sector reform and stewardship of health sector reform, and therefore of being important in recognizing that it's important in stewardship to think about politics, to think about social capital, organizational network, organizational culture and learning. These are all features of the software of health systems. And lastly, in Kabir's paper in 2011, we spoke about the dominant focus in health policy and systems research as being framed around more the hardware of health systems and addressing short-term or operational questions. And we called for health policy and systems research that would embrace the focus on software, that includes understanding the societal relevance and purpose of systems, the role of values in systems, understanding power and trust relationships within systems, and considering the influence of local political cultures. So with that backdrop, what we want to do today is to present some of the research experience of more recent years that addresses some of the software dimensions of health systems, and that allows us to think more about stewardship and what it entails in relation to health systems, health system development, health system reform. So I'm now going to hand over to Sumit and Michael, who will take forward the first presentation. Just trying to work out how to, I apologize, how to turn my mic off. And maybe the technical people can turn me off for now, and then I'll be able to move on to the slides from Sumit and
Thank you, Lucy. Lovely to be here. And today we are going to present, Michael Callan and I, our work, which involves a comparative analysis of the stewardship of the medical profession in the UK and India, and the salience of trust within this analysis. So to start off, trust has been recognized as significant for effective healthcare provision. And it has been argued that unless citizens can trust the health system that serves them, population-level health outcomes cannot be improved. So trust helps bridge the information asymmetry, complexity, and uncertainty that marks healthcare. Conceptually, trust varies from blind and assumed trust to more earned and conditional or critical trust. And there seems to be very clearly a shift from the former to the latter, due to the many dangers of blind trust that others have written about. Next slide, Lucy. Effective stewardship has been identified as a key mechanism for enhancing trust relations in the health system. According to the World Health Report of 2005, stewardship involves, among other things, the careful and responsible management of something entrusted in one's care. Stewardship, again, among other things, includes oversight and regulation of professional practice, performance, conduct, and values. Our focus in this presentation is to examine and compare, using trust and trustworthiness as an analytical lens, the recent evolution in the regulation of the medical profession in the UK and India. Drawing upon fieldwork that we conducted in India and the UK, we consider how policy approaches have differed or have been similar, and what has influenced the shape of these approaches. Turning to the stewardship of the medical profession in the UK, if you could bring on the next slide, please. Turning to the stewardship of the medical profession in the UK, I think we need to go back to 2 slides earlier. Yes, that's it, thank you. In the UK, the traditional self-regulatory approach to governance of the medical profession began to change, began to drift away from the traditional model around the early part of this century, with medical practice increasingly coming under the influence of managerial mechanisms of control. This shift appeared to be in response to a series of scandals about medical performance, and was in large parts fueled by the media. The shift also occurred due to the growing emphasis on new public managerialism, things such as audit and performance targets in UK polity. The traditional approach was characterized by a culture of high trust and limited state involvement, whereas this new shift in approach towards greater state-sponsored managerial control was both a response to, and it somehow assumed, the presence of low trust. So in 2004, the Shipman inquiry led to reforms to the General Medical Council of the UK, especially the reduction of medical dominance and oversight, not just of professional misconduct, but also the inclusion of performance as something to be overseen. This whole reform was presented as a means of securing public trust while safeguarding the independence of the medical profession at the same time. Further reforms over the following years established formal performance appraisal and revalidation assessments. Responsible officers were established and mandated to conduct these assessments, and attaining and maintaining public trust was seen as one of the key criteria in this assessment process. Now, this move away from self-regulation based governance was really dramatic, not least because the changes clearly involved the curtailment of the profession's powers. Curiously, there was not much resistance from the profession to this reconfiguration of power relations. The evidence on this so far seems to support an explanation that aligns with Friedson's thesis of the medical profession undergoing a re-stratification of sorts. That is the emergence of a distinct group of regulatory elites from within the profession who now oversee practice and performance. While the policy changes led to some erosion of power, evidence suggests that the medical profession may have yet retained a substantial degree of self-regulatory power in UK. If this is so, how might one understand the situation from a trust perspective? That's the question we ask. A perspective which is a common concern and justification for all these changes within the policy realm. Spenlove's distinction between embodied trust, which is part of self-regulation, and enforced trust, we think is very useful here. Spenlove has shown that implementing mechanisms of enforced trust, such as revalidations and performance assessments, has been very difficult in the UK. And he's also shown how no matter what, they cannot be done in a manner that it can be fully taken over by government bodies. Others still have argued that this control-oriented approach to stewardship is paradoxically fostering a culture of distrust within the British health system. We now see falling levels of trust across all relations between doctors, managers, and citizens. With this as the snapshot of the situation in the UK, let's turn to the stewardship of the medical profession in India. The profession in India has historically enjoyed immense social status, and for the better part of the last century, a self-regulation based approach under the aegis of the Medical Council of India, the MCI, has worked fairly effectively. Things, however, began to change from the late 90s, and we saw the medical profession mired in a number of scandals involving corruption and abuse of entrusted power. At the heart of this crisis was the Medical Council of India, the MCI. In 2016, an inquiry by a high-level committee of parliamentarians concluded that the MCI could no longer be entrusted with the responsibility of stewardship of the medical profession in view of its massive failures. And not unlike in the UK, spurred on by popular media, this situation triggered a series of measures by the Government of India to curtail the medical profession's powers to self-regulate and to move towards more broad-based mechanisms of oversight and stewardship. Most significantly, this included the dismantling of the Medical Council of India in 2019 and the establishment of the National Medical Commission, or the NMC, a brand new regulatory body with, among others, increased lay membership. The medical profession in India has seen these shifts and this dismantlement of MCI as attempts by the political and bureaucratic establishment to usurp professional discretion and authority from them. Unlike what we have seen in the UK, the profession is vigorously contesting these measures in India. And while the Doctors Association vehemently disagrees, the Government of India and civil society actors see this move, see this change as being necessary for restoring and re-establishing public trust in the medical profession. Now, it is also possible to understand these shifts in India as emerging from the changes in the economics of care provision in India, especially the commercialization and the corporatization of healthcare. This trend has created conditions where people can no longer be sure about the benevolence, the integrity of the medical profession. Irrespective of whether these shifts in India have their antecedents in the scandals or in the broader changes afoot in the economics of care provision, both very clearly link into issues of trust between the medical profession as an institution and Indian society. And not unlike in the UK, this situation is complicated by evidence that in India, perhaps paradoxically, people remain very trusting of their particular their specific doctors. Now, this scenario of low institutional trust in the medical profession with simultaneous high interpersonal trust in individual doctors presents unique challenges for the NMC, the new body. While the NMC is expected to act strongly to prevent future failures, it would be remiss if it were to not leverage and build upon the high levels of interpersonal trust Indians seem to continue to have in their doctors. Now, the question is, how might the NMC go about this difficult balancing act? If, like in the UK, the NMC takes an enforcement and control-based approach, it runs the risk of fueling a culture of low trust in the health system, and in the process undermining the islands of interpersonal trust that already exist and are valued by all. Again, not unlike in the UK, the NMC also has no choice but to rely on particular medical professionals to enforce their regulations. The thing is, there existed such an elite within the earlier self-regulation based regime in India too. And they were a part of the problem. They were the problem. There is now little reason to be confident that the new regulatory regime, spearheaded by a new agency, the NMC, would be able to do anything better. Now, this comparative picture shows that despite differences in health systems, recent developments in the regulation of the medical profession show similar trends across the two countries. Both countries have experienced a shift away from a self-regulation based approach. And the evidence from UK highlights the challenges associated with implementing mechanisms of enforced and forced trust. They also highlight the inability of government structures to fully take over the regulation of the profession. The question is, how might this evolve and pan out in India? Would observations from the UK that control-focused governance and stewardship in fact fosters greater trust also hold true in the Indian context? Lucy, the next slide, please. We argue that if the UK experience is anything to go by, the NMC's disproportionately control-focused approach is unlikely to enhance trust in the medical profession in India either. In our recent work from India, we have argued that for any regulatory initiative seeking to restore and engender trust in the medical profession in India, a stakeholder governance-based implementation approach with an emphasis on shared accountability, transparency, is much better placed to foster trust, and may therefore be the more appropriate approach going forward. Looking at UK's difficulties in implementing a control-focused regulatory approach, specifically their problems in fostering and sustaining trust relations, we argue that a stakeholder governance-based approach might also be the way to go in the UK. Next slide, please. Beyond this specific analysis, our findings also highlight the importance of and the need for more and creative research to understand how many of the health system software elements like trust can be better taken into account when conducting health systems research and when implementing health system reforms. Thank you. Thank you on behalf of Michael and myself.
Thanks so much, Sumit. That's great. Can I just check, is Michael adding any commentary at the moment?
Not yet.
Okay, great.
No, I was going to, I can if you like.
Are you, you can have a minute at the moment, Michael, if you'd like.
Okay, yeah. There's a couple of things. One was actually maybe the kind of, we talked about stakeholder trust, but maybe there's also an issue about tailoring the policy to a kind of the sources of distrust. So it might be that regulation is appropriate in the context of problems with competence trust and performance trust, but when it gets into the area of intentional trust, maybe we need to have a combination of policies which bring into account transparency and accountability that Sumit was talking about. The second point is quite interested in this kind of difference between patient public views of their doctors and the institutional trust, and this kind of almost an emphasis on individualistic concept of trust, the kind of neoliberal concepts of trust. And the question is whether patient trust on an individual level is more important in terms of governance than at a collective level. And it may be that patients maintain trust on an individual level when the medical profession are under more collective scrutiny. So the final point is, I think we need to think about the relationship between the response to COVID-19 and the position of the medical profession. In the UK, I think the medical profession's trust in the medical profession has been very much linked to the general loyalty and support to the NHS, and has enhanced the trust in the ethical and moral values of the medical profession. So I think it's important to put this in the current context. But I'll stop there.
Great, thanks so much, Michael. Thanks so much, Sumit. Really interesting reflections on such an important issue. The regulation of the medical profession, forms of policy, the interaction with trust. Fantastic, a great start. Can I encourage participants to insert any questions they may have into the Q&A function? We'll get back to them later, but I'm now going to invite Steph to take us forward, and I apologize about my ropey start to PowerPoint presentation earlier. I think I'm on track now, Steph, so over to you.
Thanks, Lucy, and colleagues for the opportunity. I'll go to the next slide, Lucy. I'd just like to first acknowledge the traditional owners of the land on which I live and work, the Bindal and Woolgoorookabar people, and pay my respects to their elders past, present and future. Next slide, please. So this was somewhat addressed by Lucy's presentation, but I just wanted to quickly recap on sort of a couple of key definitions of stewardship relevant to the work that I'm going to describe. And that is this idea of stewardship of health systems involving both leadership to and oversight of the organisations and programs that exist to achieve national goals. And in what is to follow, I really want you to keep your eye on two pieces in particular of the definition at the bottom there from the WHO that I think are important. And that is that stewardship does involve setting goals, of course, but also putting in place the rules, the conditions necessary to attain those goals. Next slide, please. So jumping quickly then to the setting of the Australian health system, some, perhaps many of you, would be aware that in Australia, health outcomes for Aboriginal and Torres Strait Islander peoples are substantially poorer than those for non-Indigenous Australians. And since the mid-1980s, this fact has underpinned various policy actions, including the development and publication of a rolling series of national Aboriginal and Torres Strait Islander health plans. And on this slide, you can see the three key goals listed in the current iteration of that plan. And I draw your attention in particular to the second of those goals regarding making health systems accessible, culturally safe, and appropriate and responsive for Aboriginal and Torres Strait Islander people. Next slide, please. So cultural safety is a concept that typically encapsulates the need for, in this case, health services to be designed and delivered in ways that are sensitive to and appropriate for Aboriginal and Torres Strait Islander peoples and other cultural minorities. And here on your screens, an example, somewhat invisible, I grant you, of the cultural competency framework from Queensland Health. So that's the Department of Health from the state where I live and work. Implicit in some, although perhaps not all people's use of the concept of cultural safety is recognition of the fact that in the mainstream Australian health system, systemic racism is a feature. And so working towards cultural safety is therefore in part to be understood as a reparative action. And a working assumption of the research I'm going to talk about then is that all health system actors have to be committed to cultural safety, but not all are equally capable of carrying out the foundational work required in our frontline services. Indeed, a legacy of targeted and structural violence towards Aboriginal and Torres Strait Islander peoples at both the state and federal level in Australia means that this work, in the absence of Aboriginal and Torres Strait Islander health providers, is actually likely to be impossible to achieve. Next slide, please. So against that backdrop, the remainder of the presentation is focused on a particular, very distinctive cadre of health professionals in the Australian and Queensland health system, Aboriginal and Torres Strait Islander health workers. And the Aboriginal and Torres Strait Islander health worker role is only one of two identified positions in our mainstream health workforce. An identified position is one that must be occupied by an Aboriginal or Torres Strait Islander person, recognising knowledge and or competencies that non-Indigenous Australians do not possess. It's a mixed role involving responsibilities for health promotion, some clinical services, as well as cultural brokerage. And it's this cultural brokerage component that is hardest to describe, but also what makes the role truly unique. It constitutes a bridging, linking, mediating role that supports Aboriginal and Torres Strait Islander clients in their interaction with mainstream health services. In our primary health clinics in Australia, Aboriginal and Torres Strait Islander health workers are the only providers with a terms of reference that specifies responsibility for cultural brokerage. And so the role carries particular significance. Next slide, please. So the overarching aim of the project that I'm describing was to investigate the governance of Aboriginal and Torres Strait Islander health workers. But as we progressed through our analysis, the role of health system software and its interaction with stewardship of this particular cadre of health workers emerged as a really important theme. As you can see from the map, we did this work in the Cape York Peninsula and Torres Strait regions of North Queensland. So the very pointy bit on the top right-hand corner of the map of Australia. And it's supported by the participation of 51 Aboriginal and Torres Strait Islander health workers from that region, 19 non-Indigenous health professionals, 8 community members, and 5 key policy stakeholders. Next slide, please. So I'm going to tell this story a little bit back to front, in part to address the question that this session has sort of asked us to engage with. That is, what is system software and how does it influence stewardship? I think even from the brief background that I've provided, we can agree that there are at least the bones of system hardware in place to address that goal of delivering on cultural safety. We have a national Aboriginal and Torres Strait Islander health strategy that states cultural safety as a key goal. We have a state-based cultural competency framework that translates those goals into the state setting. We have a cadre of dedicated health workers whose terms of reference includes an explicit remit to tailor services in ways that are acceptable and appropriate. And allowing for the fact that more resources would always be nice, the Australian health system is not what any of us would call, globally or comparatively speaking, a resource-constrained one. The problem is that over the past decade, despite increasing policy emphasis on cultural safety in our health system, the number of Aboriginal Torres Strait Islander health workers, this key role entrusted with being the face of the system and carrying out cultural brokerage, is actually declining. And I would suggest, and I think the findings from our research suggest, that a key reason for this is because the system software belies the system hardware that we have in place. I think that it was assumed, as is so often the case, that as long as hardware was in place, all else would follow. But as this health worker down here on your bottom right rather pithily commented, health workers are not a vending machine where you just press a button and out pops a more culturally responsive health service. It depends on a whole lot of things. Next slide, please. So our interviews really highlighted how the combination of a poor understanding of the health worker role by non-health workers, combined with a very common phenomenon in our modern health systems, which is risk aversion, are combining to make the management of health workers at the front line very punitive. Clinic managers and clinical colleagues who we interviewed often talked about the lack of clinical governance and the risks that this introduced, the lack of clinical governance specifically related to Aboriginal and Torres Strait Islander health workers, but they also couched their observations against their own lack of confidence or understanding about what it was that these health workers were meant to be doing. And a key consequence of this was that the Aboriginal and Torres Strait Islander health workers that we spoke to, almost to a man and woman, talked about their experiences of being micromanaged, a sense of lack of recognition from the clinic level right through to sort of macro aspects of the system, and the effects that that had on their service. Next slide, please. So the question becomes, why is there such a disconnect between these federal and state policies whose aim is to include cultural safety and which mandate the investment in Aboriginal and Torres Strait Islander health workers, or the role, and these frontline practices that imply a real lack of understanding, a lack of respect, if not racism, a lack of decision space for this unique cadre of health workers? One reason is that Queensland health, as are many, perhaps even most modern health system, is one firmly rooted in a biomedical paradigm. And that means that the beliefs of those who make key operational decisions, notably directors of regional service clusters and the managers of the clinics, have been trained and oriented in biomedical models of care that position illness at the centre of their service delivery and health professionals as the experts to fix it. And this approach really fundamentally clashes with Aboriginal and Torres Strait Islander people's understanding of and approach to health and healthcare, which is far more holistic in nature and actually far more aligned with the tenets of comprehensive primary healthcare than those of a biomedically oriented health system. But the belief stemming from the dominant knowledge system and service model in these clinics makes these more culturally informed belief systems and models of health very difficult to operationalise. Next slide, please. The organisational values of Queensland health system also make the realisation of the goal of cultural safety through the work of Aboriginal and Torres Strait Islander health workers very difficult. As in many modern health systems captive to a neoliberal logic, the organisational values we identified in accounts of the system highlighted the primacy of safety, efficiency, timeliness, and performance or corporate accountability. And these values were perhaps best embodied in the central importance placed on key performance indicators, which rewarded both individuals and at the clinic and regional levels for their instances of care. And many health workers described these KPIs and associated reporting systems as devaluing the much more time-consuming and emotionally labour-intensive relational work that they felt compelled to do and were trained to do with their clients, but which were neither recognised and were not uncommonly criticised or even punished by managers who perceived that to be a waste of their time. Next slide, please. Several deeply rooted organisational norms common to the clinics were also found. Two that came through very clearly in our interviews were first this grounding of authority to make decisions about service planning with the most highly clinically qualified individual, an explicit preferencing of biomedical expertise over cultural expertise. And second, and related to the earlier mentioned values of efficiency and accountability, a workplace norm requiring presence in the clinic, as opposed to conducting community-based outreach, for example, in order to demonstrate accountability to the system. Next slide, please. And so despite the presence of national and statewide policy goals and the recruitment of a cadre of health workers who carry explicit responsibility for strengthening cultural responsiveness and safety, we have a situation in which, at least amongst those working in Cape York and Torres Strait regions of Queensland, they find their ability to deliver on that intention blocked on a daily basis. And in this final slide, I just wanted to give you a chance to reflect not just on the undermining of the broader system-wide goal of delivering culturally safe service, but also the impact on the individual health workers and indeed the viability of the profession itself. What it says about the one-way direction that accountability is being perceived. This one participant on the right said, people get tired. They get tired. After tiredness comes frustration. After frustration comes anger. And then they say, I'm going, mate. So stewardship can't just be about setting goals. It also involves putting in place the rules that define how those goals can be attained. And I think what we've shown here in just one sort of health system microcosm is the way the beliefs, the values and the norms of the system are absolutely fundamental to that process. Next slide. So I just wanted to quickly acknowledge the amazing team that I worked with on this project, Sean, Joss, Rachel and Veronica. And final slide, also to acknowledge our institutional partners and the Hot North Collaborative for funding that supported this work. Thanks a lot.
Great, thanks so much, Steph. Another really interesting presentation focused on such an important issue. We've had two notions that seem to link to stewardship come out so far: stakeholder governance, cultural brokerage, both interesting thoughts. There's more, of course, but I'm just highlighting those two. And now we're going to turn to our next presenters. Just a reminder that I'm going to pop up another poll, so asking you to look at that poll as well. But now let's turn to our third input from Lisa and Dorothy, and please just tell me when you want me to move things on. Thank you.
Thank you, Lucy. Good afternoon, good morning, everybody, depending on where you are around the globe. I'm going to kick off a presentation that Dorothy and I are going to be giving about the rigorous research that has been done globally around patient experiences and the potential power and utility that has to both give us roots into the soft intelligence that we've been exploring as part of this presentation this morning, and also think about ways that we can actually make that soft intelligence actionable. Next slide, please. So I'm just going to start off with this quote from the Journal of Medical, American Medical Association from about a decade ago now. Narrative is often maligned as anecdote and thus scrubbed from the toolbox of guideline developers, epidemiologists and regulatory scientists. But these experts should consider narrative to develop and translate evidence-based policies. Next slide, please. And what we're going to do in this presentation is explore the potential for understanding and utilising patient and staff experiences to guide research that can inform practice and health system improvement, and explore how evidence from patient and staff experiences might be used in other areas like prioritisation, systematic reviews and things like that. Next slide, please. So why do patient and staff experiences matter? Well, experience is one of the three pillars of the quality of care as outlined by the Institute of Medicine, alongside safety and effectiveness. And there are now increasingly well-established links between positive and high patient experiences and self-rated and objectively measured health outcomes. And growing evidence that suggests that patient-centered organisations around the globe have better clinical safety, decreased mortality, improved staff experience, staff morale, and crucially retention, lower operating costs, shorter lengths of stay, and reduced malpractice claims. So there's a lot working in experience's favour. Next slide, please. And there's a role for situating qualitative patient experience evidence alongside quantitative data that we collect about our health systems all the time. Insights from patient and staff experiences, those qualitative tactile insights into those experiences, can allow us to assess what an experience is currently like, and then measure if improvements actually make a difference. They can allow us insights into why an experience is poor and help us generate ideas for change. And they can tell us not just what is wrong in a very binary way, but can actually help us generate ideas and understandings about what good looks like in a health system and what could be better. And patients often, we find, suggest very simple changes. They're not changes that are going to cost huge amounts of money or place great burdens on government and system budgets. Patient experiences can challenge assumptions, and often we find that things matter less to patients than we think, and they can be a really powerful motivator for action and remind us what we're trying to achieve. Next slide, please. What I'm going to be talking about in the first half of this presentation is an approach to collecting and utilising patient experiences data that was originated over 20 years ago in the UK, but now has a global following and an international collaboration. And I'm just going to be talking through a couple of examples and show you some of the uses to which that form of evidence has been used to impact on soft intelligence of health systems, before handing over to Dorothy, who's going to be talking about the work that we are just starting in Kenya. So the approach is to collect national maximum variation samples of people with a particular health or social care condition. So we are very focused on collecting open-ended interviews with a broad range of people from around a particular nation. In the United Kingdom, it would be from all 4 nations of the UK, but in Australia, it would equally be a nationwide study. These studies are based on open-ended narrative interviews with around 40 to 50 individuals with a particular health condition of focus. They are funded through peer review research streams, and once we've collected the interviews, we do a thematic qualitative analysis of the main findings to publish peer review clinical and social science journals, but also to publish a web resource, next slide please, that was established by these 2 individuals 20 years ago. Anne Macpherson was a GP who was based in Oxford, and Andrew Herxheimer was a pharmacologist. They've both died. We lost them both in the last decade. But in the early part of this century, they came up with the idea of developing a repository for patient experiences that could be used by others in the future, both as a resource for other patients and their family members, but also for health professionals and medical trainers, medical educators, and commissioners. And out of that initial idea, next slide please, was born what was originally called the DIPEX website, but is now called Health Talk, which is a free website, non-commercial multimedia that's accessible globally. The Health Talk that I'm showing you here is the one that's based in the UK, which has now over 110 studies of different health conditions covered on it. Each of those conditions is based on interviews with between 40 and 50 individuals. And the thematic summaries that are written for the website are illustrated with video and audio clips from the interviews. What I'm showing you here is the portal for the UK site, but there is now an international collaboration that includes 13 countries from around the globe that have similar country-specific projects. And in a couple of slides' time, I'll give you a flavour of where they are spread around the globe. Next slide, please, Lucy. In addition to the website and the support that is able to offer to other patients with similar conditions, other uses have been developed for these patient experiences insights, which I think give you a flavour for the range and the diversity that these insights into soft intelligence can be used in terms of improving health systems. So in addition to the engaging video-based resource, they are also used as materials for training clinicians and medical students. They are an archive of rigorously collected qualitative research that can be used for secondary analysis for future studies. And they have been used extensively as a platform for stimulating service improvement and co-design based on what matters to patients. And of course, they've, as I've already mentioned, established an international collaboration. Next slide, please, Lucy. Just to give you oh no, sorry, we've got to click through all those ticks. Sorry, I'd forgotten that feature. This one, thank you. So in terms of teaching, we know that in the UK, at least, the Health Talk resource is used in over 80% of medical schools. These studies by former colleagues in Oxford give a flavour for the understanding of the power of using those insights into for training. They've also been used, next slide please, in clinician training, and this slide gives you a flavour of the international range. So our German colleagues have used their national studies as a training module for case managers in governmental retirement insurance. Our colleagues in the Netherlands have developed an educational module on their research with coping with dementia for students of intermediate vocational education. In the Czech Republic, colleagues there have developed workshops for psychologists, psychiatrists, and somnologists to share experiences of the first study that they did in the Czech Republic, which was a study of patients experiencing nightmares, which always fascinates me that was a particularly pressing clinical need in the Czech Republic. And in Australia, there are multiple modules that have been used in online training programs for professionals, in particular those specialising in perinatal mental health and severe asthma. Next slide, please, Lucy. And they've also been used, these resources have been used for quality improvement. So in Germany, catalyst films have been developed with suggestions for improvement using quality circles in rehabilitation clinics. In the Netherlands, they have been used to develop ideas for improving the care and well-being of dementia patients. In Norway, plans have been developed to develop improvement strategies for young people with chronic conditions. Australia has used their various modules in terms of developing management algorithms for health professionals. And in the UK, we have a very nice example that was developed before the current pandemic that is currently putting so much pressure on our intensive care units here in the UK, using insights from interviews that we conducted about a decade ago with intensive care patients to stimulate ideas for reducing noise on the intensive care units. Next slide, please, Lucy. So, and I think you have to click through and it's going to pick up some flags. There you go. So this slide gives a global overview of the countries that have been enthused by this approach and developed similar research groups and are developing similar resources in their own countries. You will notice that those are across the board thus far from high-income countries, and that's something that we have been seeking to redress and explore the potential for developing rigorous patient experiences research in low- and middle-income countries and testing out the potential in those health systems for how these insights into the system software from the perspective of patients' experiences can be used to improve health systems. And I'm now going to hand on to Dorothy, who will tell us more about the work that she has been leading in Kenya. Thank you. Next slide.
Okay. Are you unmuted, Dorothy?
Thanks, Lisa.
Unfortunately, I'm not hearing Dorothy. Hello.
Can you hear me?
Yes, that's better. Yeah.
Can you hear me? Okay.
Yes, now.
So, okay. So, thanks, Lisa, for providing that background. We see that newborn care is highly dependent on nursing care. However, the health system grapples with acute nursing shortage and high patient nurse ratio. As such, mothers and families like sick newborns.
Hello. I wonder if others can hear Dorothy, or is it just me? Lisa, can you hear?
No, the sound is very patchy. Dorothy, I wonder if turning your video off might help. If not, I could talk to these slides.
I think maybe just in lieu of time, Lisa, if you would. That's a great shame, but if you would. Maybe our tech assistants could, I'm afraid, mute Dorothy and allow Lisa to talk, and we'll hope to get Dorothy back in the Q&A. Yes. Sorry, Dorothy. So Lisa will present your slides.
Yeah, I'll take over. So thank you, Dorothy. Sorry that the internet is not supporting you being able to talk. So this is Dorothy's work. Can I make that very clear before I start? And Dorothy has, as part of her doctoral studies, has conducted patient experiences work in Kenya, looking specifically at the context of hospitalized newborn care. And the context there is the subject of an ongoing programme of work that has been led by Mike English and others in the Kembury Wellcome Trust programme, and they have been exploring the quality and the range of care provision in newborn units. Care provision within newborn units is highly dependent on the adequacy of nursing care, and previous studies have shown and demonstrated that there's an acute shortage of nursing staff, coupled with a very high patient workload. There's a big turnover of these premature babies requiring neonatal care in both Nairobi and other urban centres in Kenya. We know from previous studies that mothers play a significant role in caring for the newborns when they are hospitalised in Kenya, but there is little documented research about the feelings and experiences of mother when they're hospitalised with their newborns. Building on Dorothy's PhD work, which was an ethnographic study and interview study with mothers in 2 newborn units in Nairobi, we collaborated to work on a small pilot project to interview a small handful of mothers who had babies in premature units to explore the potential for learning from mothers' voices. We did interviews with 5 women, and the interviews ranged from exploring the roles and practices of mothers, capturing their experiences and understanding more about their fears and concerns, and understanding the importance of relationships and interactions that were enacted within the neonatal units, both between the mothers and the nurses, but also, more surprisingly, and this is one of the emergent findings from Dorothy's work, is actually the support mechanisms between mothers and the potential supportive power in those relationships. So there were both formal relationships and informal relationships that were incredibly potent. And we produced a short film that gives a sense of the potential for learning from mothers' voices through video and audio interviews, which you can see at that link if you're interested in following it. Next slide, please, Lucy. Dorothy's doctoral work was based on an ethnographic study using observations in 2 hospitals in Nairobi County. Dorothy used non-participant observation during hospitalization of newborn babies to understand the context and the roles played by mothers, the interactions between mothers and staff, and mothers and staff and the baby, and the fear and concerns of those mothers. In total, she conducted 318 hours in one and 321 hours of observations in the other hospitals. Subsequently, in-depth interviews were conducted as mothers were about to be discharged home with their babies about their roles and perceptions and fears. And then there were a further 20 interviews conducted. So the 20 interviews were conducted retrospectively there. And then Dorothy was able to follow those mothers up, 6 of those mothers up, and collected 6 further narratives post-discharge to explore at a more extensive level the personal narratives of their experiences in hospital. Thank you, Lucy. Moving on to the next slide. This approach has surfaced a number of methodological and ethical dilemmas that if we want to pick up in the discussion, we'd be happy to. And I think these speak to the challenges of capturing and utilising these forms of soft intelligence. So at a pragmatic level, the challenges to producing this sort of evidence in terms of power dynamics between researcher and participant, or between the participant and other members of their families and cultural groups, and also finding the right private venue. There are ethical issues to consider in terms of how this evidence might be used. And the key questions going forward that we will be exploring as we develop this work further in Kenya is how these forms of evidence might be utilised and evaluated, further extend the patient experience work to capturing staff experiences, and to try and explore what are, in the Kenyan context, the most useful practical platforms to deliver this form of evidence. Next slide, please. Yes, sorry. So our work is, we are just starting a new programme of work which will be further extending the work that Dorothy did as part of her doctorate. We will be collecting more narratives with mothers beyond Nairobi, seeking to broaden and diversify the sample. And then we are going to be developing specific quality improvement strategies targeted at neonatal nurses to evaluate the impacts of these patient experiences insights through the development of digital training materials and an evaluation of those interventions. Next slide, please. That's just a lovely final quote, "No numbers without words," from Andrew Herxheimer, who was one of the founding members of the DIPEX and Health Talk organisation. And I'll stop there and hand back over to you, Lucy.
Thank you so much, Lisa. And I'm so sorry we couldn't hear Dorothy, but it's great that we've had a chance to hear a little bit about her work as well. So 3 fascinating presentations discussing aspects of trust, of software and stewardship issues. And the last one also speaking about methods to gather these important patient experiences. So we have 13 minutes, colleagues, and I wonder if we could, I'm going to stop sharing. Just a reminder, these are the 2 questions we'd hoped to think about, but I wonder if we could all turn the videos on, but mute unless you're talking. We have some questions already online, and I encourage other questions to come through as well, so please do submit your questions. I'm going to go straight to the questions because we have an audience who've been engaging with us. Also need to put my video on. There we go. I was gesticulating at the screen. So I'd like to pose the first question, which was to Sumit and Michael. And it's from Helen Schneider in South Africa. And the question's about the idea of stakeholder governance. Who convenes it? What space could there be for it in the wider organizational context where the sort of imperatives of new public management still seem to dominate how health systems function? We've got 12 minutes, so it's not a long answer, colleagues, but maybe Sumit first and then Michael, some reflections on that.
Thanks. Yeah, Helen, I was thinking about your question. I saw it coming in, and let me speak about India, and then Michael can come in about to speak a bit about the UK. In India, at the moment, the situation is that the medical profession has dug itself into a deep, deep corner. And if the answer is to be a practical answer in terms of what might such a platform be, who might convene it, what spaces decision space might exist to make that happen. At the moment, we are in an impasse. Both the government and the profession have dug themselves into a corner. My sense is that over a period of time, civil society organizations, which are trusted both by the state and by the profession, would probably have to step in and provide a platform and convene a forum where this can be negotiated and arrived at. The worst case scenario is likely to be that as things have somehow panned out in the UK, the professional elite will go back and forth between pandering to the demands of the profession, which as a medic myself, I think are fairly unreasonable at the moment, and the demands of the state, which are within the spirit of the new public management, very control focused. So the civil society organizations of some kind will probably step in.
Thanks, Sumit. Michael, any reflections?
Yes, the stakeholder model, I think, was toyed with by the Labour administration in the late 1990s in this country, in the UK, in terms of primary care groups and health action zones. The idea was they'd be kind of devolved to local agencies working within the local organizational structure with kind of more central strategic control. And the notion was very much working in partnership. It's based on communitarian values, and actually with a big emphasis on mutual trust, reciprocity, and important engagement of citizens and the public involved in these consultations. And it reminds me of the kind of more recent attempts of co-production. But the questioner is dead right in a sense that this was kind of eclipsed by the shift towards performance management and the kind of emphasis on so-called objective evaluation of performance. So it was kind of toyed with, but sort of dropped. But I think there is potential for that, particularly this emphasis now on co-production and the role of patients and patients groups and civic society. And I think in India, what I picked up when I was last there was this kind of shift of emphasis of stakeholders, increasing civic society involvement, increasing corporate body involvement, which was very much a kind of small self-regulation, increasing corporate body, insurance companies. So there's a whole range of stakeholders there that actually are influencing policy. So it's a good question about the space. I'm not sure about the space given the emphasis on NPM, but maybe in India there's more space for that.
Great, thanks, Michael. So we have 8 minutes just to keep you on track. So Steph, there's a couple of questions for you. So I'm going to give you both questions and then going to come to Lisa and Dorothy. So Steph, also from Helen, in your interviews with the health workers, did they reflect on governance models that might redistribute power to give them voice and challenge dominant norms? And from Kranti in India, how does the Australian government address the medical knowledge of the Indigenous people and integrate it into mainstream health systems? Not small questions, but short answers.
Thanks for the great questions. In response to Helen's question, sort of 2 quick responses that deserve a lot of unpacking. But one is that the responses of the health workers from the Torres Strait region were quite distinct in this respect to the health workers in Cape York. And the reason is that both culturally and administratively, those regions actually, although they are currently administered under the same sort of local government area, culturally they are utterly distinct. And historically, they were actually also administratively distinct. And in the Torres Strait region, there is still nominally in place a governance and service model called the Torres model of care, which was designed in the mid to late 1990s and which mapped very closely to a comprehensive primary healthcare model and was designed for the health system structures to be linked at each level to a local either council or cultural body such that decisions were consultative throughout. There's a whole lot to be said about that, but the nutshell is that for a whole range of reasons, many related to sort of power struggles, that model has atrophied. In the Cape York region, that model was never in place, and so the suggestions from the Torres folks was always, well, look, we need to recapture the Torres model of care, which in its original form worked incredibly well for integrating Indigenous knowledge and shared co-produced health service planning models really well. But in the Cape York region, that model has never been in place. And so the suggestions were, I guess, less transformative and involved sort of trying to think through the ways to carve out better representation of health workers at different levels of the existing governance model, which I'm not sure, to be honest, is going to address the systemic nature of some of the things that we're discussing. And then very quickly,
Steph, I wonder,
yeah, sure.
I beg your pardon, I wonder if you'd reply to the other one on the text, and then we can just allow Lisa and Dorothy. Thank you so much, and thanks for the answer. So Lisa and Dorothy, we've got to co-production in both previous responses, so entirely appropriate to come to you. And there are several questions. I'm going to just highlight. Marsha Orgil from South Africa is asking if the research has already been fed back to the mothers themselves and their responses. Helen's asking the HIV experience in South Africa and social mobilization around that was key to mobilizing to the shifting patient-provider relationships. Have you seen shifts in patient-provider relationships in your work? And Sumit's asking about the mix of hardware and software in patients' accounts of how they experience care. We have 4 minutes, so I'll give you 2, Lisa.
I'll talk really fast. So firstly, the first question in terms of feeding back to mothers, yes, we have fed back to mothers, both in terms of making sure they're happy with us using the clips that we use, but also showing them the video, and feeding back is a key part of it. To come to, I think, Helen's point about social mobilization in around HIV in South Africa, I'm not familiar with that movement per se, but I think what I would say is what we're talking about with this patient experiences research is not advocacy, but another tool in the evidence box that might sit alongside evidence-based medicine toolkits. So it becomes a form of evidence and understanding the lived experience that can be used, as I talked in the presentation, in multiple ways, one of which might be in terms of policy advocacy, absolutely. So there's potential for that, but it's a new form of rigorous evidence. And then quickly to try and touch on your question, Sumit, in terms of hardware and software. These in-depth insights into patient experiences are primarily aimed to try and capture what's important from the patient's perspective and the lived perspective of the full experience. That will inevitably draw out the soft experiences, but it will touch on some of those hardware issues and where the lived experience butts up against some of those structural systemic issues. And I think it's often not framed that way in the thematic analysis, but I think if you go looking for it, there's absolutely examples of how patients struggle with the hardware or are facilitated by the hardware, but how the soft and the hard have to sit alongside each other. How did I do? 90 seconds?
You did well. Thank you very much. We've got that hard time issue.
Yeah.
So thank you for the responses. There's another question about how to inquire into values in areas where disrespect and cultural differences are normalized. So I acknowledge the question. I'm not sure that we've got an immediate response. I want to ask every panelist to conclude with the priority that they would say there is for research on software and systems. And it's like 3 words, colleagues, each. Sumit, I'm going to you first.
Trust and trust.
Great. Michael. Mute, you're unmute. You need to unmute.
Evidence to assess policies for building trust.
Fantastic. Steph.
Trust, power, and accountability. Triangle.
Lisa.
Developing an evidence base for the impact of patient and staff experiences.
Fantastic. And I don't know, Dorothy, if you're still there, have you got a word to suggest?
Yeah, I hope you can hear me.
Go for it. You've got 40 seconds.
Yeah. So frameworks that bring on board the patient voices to the policy table.
Fantastic. Thank you very much. I really appreciate all of the inputs. I'm sorry the time wasn't enough to really get into the details of them. I feel we've ended with a set of concepts that need further inquiry, but also a set of voices that we need to hear. Patients, health workers, medical profession, but also patients in relation to the medical profession. And if nothing else, I feel that systems and software are about understanding systems as people and needing to unleash the positive power of people. And that does require us to think differently about methods and appropriate concepts. So I thank you all. I thank the audience, and I look forward to continuing engagements. Thank you so much indeed, and see you on the other side.
Thank you, Lucy.